KIF, Health Treatment Undertaking Services, presents to you KIF, Health Treatment Undertaking Services, presents to you KIF, Health Treatment Undertaking Services, presents to you
Good evening. On behalf of the KIF Health Treatment Undertaking Services and Professor Aisha Al-Dahiri, the Chair of Nutrition and Health Symposium webinar series, we are pleased to welcome you all to the NHS 2020, which is in collaboration with Emirates Nutrition Association. The Nutrition and Health Symposium aims to establish a platform for societies, organizations, academians, researchers, experts, and students to exchange the latest knowledge in the field of nutrition, to discuss the latest research and challenges we currently face. In the light of current health situation, NHS will be conducted in series with interactive sessions virtually. Each series will be accredited by Department of Health Abu Dhabi with not less than 1.5 CME hours. We would like to take this opportunity as well to thank our NHS partners. SpecBright Group collaborated for today's webinar. Abbott Laboratories SA scheduled to be live on Saturday, 26th of September. Nestle Health Science, which will be conducted on October 31st. And that KIF will sponsor the last series around November of this year. Once again, we thank everyone, our collaborators, speaker, and attendees. We look forward that all will have a great time and informative lecture outcome throughout the NHS webinar series. Before we proceed with our webinar for today, please be reminded that our course attendance is being monitored for the number of minutes you are connected to calculate the CME hours you will be receiving. Once we have gathered and finalized all attendees' minutes of attendance, you will receive an email from us next week with 2 links. One is the evaluation and the other one is the post-test as a prerequisite of DOH. For those who will complete both links, we will send within 10 working days the copy of your PDF certificate along with the presentation of the course. Please note that the online post-test and evaluation portal will only be open for 1 month from the date of the course. Make sure that for those who are able to attend to fill out both forms to get your certificate. We also would like to invite everyone to please follow, subscribe our social media accounts, Facebook, Twitter, Instagram, LinkedIn, and YouTube under the TIF Health Treatment Under Services account to receive the announcement of our upcoming courses as well as view the previewed recorded session. With that, for those who are unable to join today, we are simultaneously live through our YouTube and Facebook account, which will be open for a few weeks. We would like also to request our attendees to please type your questions, comments, or any clarifications in the Q&A box below your screen, which we will address at the end of the lecture. Without further ado, we are pleased to reintroduce to you our speaker for today, Dr. Inas Al-Alawi, who will inspire us with her lecture regarding body composition analysis, an assessment tool for bariatric surgery. Dr. Inas, we welcome you to NHS first webinar series. The question you have provided to us are ready to release as a poll questions. Just let us know when you want it to release. At the end of today's lecture, before we proceed with Q&A, we have Spec Bright Group who sponsored our course for today to present a short presentation for us. Thank you so much, Dr. Enes, and we can start from here.
Oh, thank you very much. Good evening to you all. I hope you can see my slides, and if you can't, Kim, you'll help us. Do I share screen?
Please, can you share your screen?
Okay. Please let me know if you can see me clearly. Is my slides clear?
Yes, your slides is clear and your video is clear.
Am I full screen with the slide?
No, not yet. Now, yes.
Okay. Okay, good evening all. As you know, thank you for your introduction, Kim. My name is Inas Al-Alawi. I am a bariatric surgeon. So I will speak to you today regarding body composition analysis and its use for bariatric surgery. I would like to apologize to my colleagues, the dietitian, the internist, and all the other fields who are better than me in using the body composition analysis. But I'm here today to explain to you how this is important to me and my patients in my specialty. Please allow me to share this information with you. So this is what we're going to talk about today, and we'll focus on bariatric surgery and using the body composition analysis as an assessment tool for the preoperative period and the follow-up period. Our learning objective today, the first thing is I would like you all to know that there are many procedures available for bariatric surgery. So I'm not going to talk about a sleeve or a bypass or a balloon or a gastroplasty. We are going to talk about bariatric surgery in general. So with all the procedures that are available, I would like you to learn that there are more than 48 procedures out there, and you need to assess your patient before you choose the right procedure. So again, to choose the appropriate procedure, restrictive, malabsorptive, temporary, permanent, you've got to assess your patient right, and we're going to talk about this in the coming slides. Different procedures are suitable for different patients. So I'm going to give you an overview of which patient is more suitable for a restrictive procedure, for example, the sleeve gastrectomy, and which patient is more suitable for a malabsorptive procedure like the bypass or the biliopancreatic bypass. I'm not going to give you too much surgical details, but I would like you just to know that there are different procedures and different patients are suitable for different procedures. Assessment is very important for decision making. So you don't just open a bariatric clinic and do a sleeve gastrectomy on every patient that comes to your clinic, or do a bypass or do a balloon. You can't be procedure dependent. You've got to be patient dependent. And today I will hopefully give you an idea about the assessment that is required to make the right decision. Now, the value of the body composition analysis in a pre-op and a post-operative assessment, excuse me, of course, it's a great value. Why? Because this test is cost effective. It's cost effective, and the sensitivity and the specificity, it's decent. If the accuracy of the information I get from this analysis ranges between 80 to 85%, that's good enough for me. It's almost free. This tool is available in almost every clinic, and whether you use it or you don't use it, it's actually considered as a free assessment tool. If I send blood tests to do the assessment, something like amino acid profile, just to know about the lean mass index in the body, that's going to cost me thousands and thousands of dirhams, and it's going to take long to get the results back. But a body composition analysis is right there at my clinic door. We will talk about the assessment, the importance of preoperative optimization. If you have a patient whom you need to lose 40 or 50 kilograms, surely you need to optimize them. You need to get their bodies to be used to and ready for that weight loss mission. So let's talk about the assessment in general. What do we do for every patient who comes to the clinic requesting a consultation for weight loss? So the general profile, which includes laboratory and radiology, metabolic and hormonal profile, the gastrointestinal profile, which gives me an assessment of the upper gastrointestinal tract, so and helps me in decision making for what kind of procedure. And then the body composition analysis, which gives me the muscle fat distribution and which procedure am I going to use for which patient. Now, the lab and radiology. We do this for all our patients. Any deficiencies will be addressed and will be replaced. Iron deficiency, for example, in a male patient, you always ask yourself, why is a 40-year-old male patient coming with a low serum iron? So we assess these patients very thoroughly, and in some occasions, we have live examples in our clinic where we've discovered colon cancers, polyps, ulcers, inflammatory bowel disease. We've discovered diseases just because we assess our patients thoroughly. We do ultrasound abdomen on everyone. So in our male patients, for example, we look for the size of the prostate and if there is any prostatic hypertrophy, because that might affect the micturition after surgery. And then we think about renal stones, gallstones. In female patients, you might find incidental polycystic ovaries or uterine fibroids. Whatever you find on your assessment, you need to refer the patient to the appropriate specialty and get clearance before you go ahead and do your bariatric surgical treatment. So when it comes to hormonal and metabolic profile, we like to look for insulin resistance. We like to find whether there is a fatty liver, and we like to assess the degree of the disease and the need for treatment before bariatric surgery. Of course, most of these diseases will be treated by bariatric surgery, but you need a fit and well patients to do surgery on. Remember, bariatric surgery is an elective surgery. There is no rush. You don't have to operate tomorrow or next week. Take your time, assess your patient, optimize your patient, and then go ahead and do a good and a well-planned surgery. The gastrointestinal profile, of course, we look for acid reflux, we look for hiatus hernia, ulcers, polyps, what have you. And that is very important, again, in decision making, which surgery am I going to do for my patients? Patients with severe reflux esophagitis, with large hiatal hernia, obviously you're not going to do a sleeve gastrectomy on, and I will discuss with you the details in the coming slides. The barium meal is very, very helpful tool. Yes, I agree. It's an old, very old test. In fact, my colleagues in radiology always question me, why am I doing a barium meal, whereas I could do better procedures like the CT scan or the endoscopy? Well, my reason is there is no test in the world that would assess for me the gastric emptying time. Gastric emptying time is only accessible using the barium meal. You let them drink the contrast and you look at the time and you measure the time between swallowing the contrast and where the time where the contrast is in the small bowel. So gastric emptying time is very, very important. And I will give you some examples of the procedures of choice for the according to the speed of gastric emptying. Body composition analysis. Now, we're here today to discuss this very cost-effective, very simple tool to use. All you need to know is to be able to read it, and how do you assess the accuracy of the parameter that you're reading. So it helps to monitor fat losses versus lean mass gain after bariatric surgery. Body composition measurements gives you a better assessment of the patient's health and metabolic status, rather than depending on the BMI alone or the excess weight loss. It permits intervention if weight loss results in lean mass, in muscle mass loss. So if you have a patient who you've lost 40 kilograms of muscle, obviously you can intervene. And how else would you assess this point than doing a body composition measurement? It helps to assess the skeletal muscle mass, total body fat, abdominal girth, whether there is central obesity, and if there is central obesity, is it going to affect your risk assessment for this patient in terms of metabolic disorders and the associated obesity. Very importantly, it helps us to set up goals and outcomes for our bariatric patients. So the choice of procedure. I'm just going to very quickly, without going into many surgical details, but I'm happy to explain further if needed, about the choice of the procedure for which patient. Look at this. Restrictive procedures like the bioenteric balloon or the restrictive laparoscopic sleeve gastrectomy, they actually can be contraindicated for patients with severe acid reflux and with a high speed of gastric emptying. Now, listen to me. Regardless of how big your stomach is, regardless of how large the stomach volume is, it's very important the speed of time that you take to empty your stomach. So if you eat a meal and if you empty your stomach in 20 minutes, you're able to eat another meal after 20 minutes. And high speed of gastric emptying is, regardless of the size of the stomach, it causes obesity. So are you going to do a restrictive procedure on these patients? They don't even fill their stomachs. They don't even fill the full volume of the stomach because they empty very fast. So sleeve gastrectomy is not a suitable procedure. These people have a high incidence and prevalence of weight regain if they lose at all. And there is a high incidence of even failure to lose weight. If you do a sleeve gastrectomy, a restrictive procedure, no matter how tight you go with the sleeve, if you empty very fast, if your patient is emptying the stomach very fast, it doesn't matter the size of the stomach. They're still going to eat. They're still going to drink their chocolates or whatever the high calorie drinks. They're still going to do all that because they empty very fast. In fact, I had a patient not too long ago who put 10 bars of chocolate in the microwave and had it for her dinner after her sleeve gastrectomy. This is what people do. So if the speed of gastric emptying is very fast, then failure to lose weight is a big issue. Now, in terms of malabsorptive procedures, patients who come to you with severe iron deficiency, vitamin B12 deficiency, different minerals deficiency, are you going to do a malabsorptive procedure on them? Obviously not, because you're going to make worse their status because of the malabsorption. So please always assess your risk-benefit ratio. Always assess how beneficial is your treatment for your patient and how risky it is. So you assess the risk-benefit and no-benefit ratio and then decide what's the best treatment of choice. Assess your patient well and educate your patients. So if we talk about optimization, we replace any mineral deficiency. We consider preemptive muscle strengthening exercises, especially for the spinal patients. Let's assume you've got an obese patient with, for example, lumbar disc disease. Now, you know, when you measure their center of gravity, you will see that they're holding themselves in a certain posture that depends on certain back muscles. Now, if you don't pay attention to detail and do a procedure where they end up losing a lot of muscle mass, those muscles which are holding them in a center of gravity, those muscles can get weaker and weaker. So these patients could actually come back to you with severe back pain after weight loss. And you've done the weight loss surgery to improve their spinal problem. So please be careful and consider preemptive muscle strengthening physiotherapy for spinal patients before you do bariatric surgery on them. In the optimization period, the preoperative period, to be honest with you, in our clinic, we always give proteins and essential amino acid supplements. Now, we give them for between 4 to 12 weeks. This is not evidence-based. I don't have evidence to support this at the moment from the literature. This is just observational, but I've been doing this for over 12 years. And patients, the patient's outcome are much better than those who did not receive the optimization. For any further details or questions regarding this matter, please keep your questions coming and I will answer them. My last lecture focused on nutrition and amino acids. Our talk today is focusing on body composition analysis. So we're not going to go too much into the proteins and amino acids topic, but I'm happy to take questions later. Again, omega fatty acids and multivitamins preoperatively. This is just observation from my clinic. We noticed that our male patients are better when they receive these supplements as compared to those who did not receive supplements when you match the groups. So if you have similar groups of male patients, similar age, similar BMI, patients who did not receive these supplements preoperatively actually complain of sexual dysfunction. And we have not seen any patient complaining of sexual dysfunction after bariatric surgery when we've given them these omega fatty acids and multivitamins. Again, I'm happy to talk about these details. At the moment, I'm just giving you general points. Plastic and cosmetic surgery assessment. We try to get our patients to see the cosmetic team before we operate on them. Because if they've got central obesity, there'd be a chance of developing an apron, a skin apron, which hangs down to the thigh or even down to the knees. It's very uncomfortable. We assess the need for apronectomy later, breast lift, body contouring, whatever it takes. But we also optimize our patients with collagens and hyaluronic acid and many other cosmetic products. Let's look at the assessment tools and let's focus again on the reason why we're here today is to talk about the body composition analysis in the bariatric patient. So let's remind you of this slide again. It helps you to monitor the fat losses versus the lean mass gain after bariatric surgery. It gives you a better assessment of the patient's health and metabolic status as compared to BMI and excess weight loss. It permits intervention, if at all, if needed, in case you get very high losses in the lean muscle mass. It helps you to assess the skeletal muscle mass, total body fat, and abdominal girth for you to be able to classify your patient, whether they're apple-shaped, central obesity, or pear-shaped, which is generalized obesity. Obviously, that's going to affect your risk assessment for metabolic syndrome. And it helps you to set up follow-up goals and outcomes. For example, the Roux-en-Y gastric bypass induces changes in both the fatty tissue mass and the skeletal muscle mass postoperatively. So you lose weight from everywhere. When you do a gastric bypass, you lose weight from fat, from muscle, you lose water, you lose bone density. Everything is lost, and you have to have a way to measure that. So the gastric bypass is associated with decreased bone mineral density, decreased basal metabolic rate, and potentially the ability to regain the weight or not lose enough weight. So the basal metabolic rate is something we look at preoperatively in all patients, and we follow it up after the surgery. Restrictive procedures, in addition to malabsorptive component, would result in increased speed of weight loss. So the faster the weight loss, the more muscle loss. So overall weight loss can reflect a lot of muscle loss, not only fat loss, and that can have negative impact on the patient's well-being and the patient's general health. Now, we as bariatric surgeons, if we focus with this assessment, and if we learn how to read the body composition measurements, and if we learn how to set up our goals according to the DCA data, I think that's going to be very helpful for us to cater a better service to our surgical patients, and will help us to make better plans and choose the right procedure for the right patient. Let me give you a case study. I think this is a very interesting case, so I would like to share this with you. A 58-year-old female patient who came to my clinic with a BMI of 32.5. So this patient is considered in a lower BMI group, lower BMI patient. She was diabetic, taking medications for her diabetes. Her HbA1c was 6.3. She was dyslipidemic. She was taking medicines for her hyperlipidemia. She had fatty liver. She had hypothyroidism and was taking thyroxine, 75 micrograms per day. She had a lot of back pain because of kyphosis and lumbar disc disease. She could not exercise because of the back pain, and therefore she came to clinic complaining that even she's a lower BMI, but she's suffering metabolic syndrome, and she requested assessment for surgery. When we assessed her body composition measurements, of course, bearing in mind that this is a spinal patient, she's got lumbar disc disease, it was very important for me to make sure that if I do surgery for her, I give her a better lifestyle and not tire her out and give her pain. So the skeletal muscle mass on presentation to the clinic was 22 kilograms, and her normal range was between 22 and 27. The body fat mass was 33 kilograms, and her normal was between 11 and 18 kilograms. Look at her abdominal girth. Although lower BMI, she was central obesity. Her abdominal girth was 107 centimeters. Her chest and her hip was 102 centimeters. So 107 centimeters in the waist, 102 centimeters in the hip and the chest. So we classified her as a metabolic patient with central obesity, therefore qualified for bariatric surgery. So we made a plan to give her mini gastric bypass, because according to the assessment and all the tests and investigations that we did, mini gastric bypass was the most suitable procedure for this particular patient. So what have we done? Preoperatively, as an optimization, we've given her preemptive muscle strengthening physiotherapy. And we discussed with the physiotherapy team. Our senior physiotherapist is very interested in this topic. In fact, she's now collecting data for an audit and an observational study. So she's comparing those spinal patients who qualify for bariatric surgery. Would they benefit from the muscle strengthening exercises in terms of helping their back pain or the spinal issues in the future? So this patient, after discussion with the physiotherapist, we've decided that 1 session per week for 6 weeks would be a good idea. There's no evidence for this. There are no guidelines. This is just something that we do in our clinic, and we're observing, and hopefully within the next few years, we'll come up with an observational study to tell us how helpful this phenomena is. So for this patient, we've given her oral essential amino acids for 6 weeks. We've discussed with her diabetologist, and we've got clearance that there is no contraindications for amino acids, and we've given her the amino acids for 6 weeks. Now, why 6 weeks? Why not 2 weeks? Why not 3 months? As I said, this is just observational. Now, look at the results. Look at what happened. Look at what happened. This is what happened after the 6 weeks optimization. Remember, her BMI was 32.5. Her BMI now is 34.5. So she's increased in her BMI in 6 weeks. Her weight was 82. Now she's 87. So in 6 weeks optimization, we've increased her 5 kilos. But look at the skeletal muscle mass. Remember, it was 22 kilograms and now it's 27. The body fat mass was 33 kilograms and still is 33 kilograms. So after the optimization with amino acids and muscle strengthening physiotherapy, we've increased the skeletal muscle mass by 5 kilos, which had given her weight gain and has given her a higher BMI, but it's all in the muscle. We like that. We thought that would be very beneficial for this patient's spinal problem. The abdominal girth had actually increased by 1 centimeter everywhere. Her waist was 108 centimeters, the chest 103, and the hip 104. So yeah, you made a bigger patient in 6 weeks optimization, but look carefully, the parameters which had changed and increased the weight was mainly in the skeletal muscle mass. So that was mainly lean muscle. Let's look at what happened post-operatively. I'm giving you now the assessment which was done 3 months post-op and 6 months post-op. Remember her weight, and look at her weight now. Within 6 months of surgery, her weight was down to 71. Her BMI was down to 25. HbA1c after 3 months and after 6 months had come down, so her diabetes was better. Skeletal muscle mass 3 months later got down to 26, and 6 months later to 25, still within the normal range. When she presented to the clinic, she was 22, at the lower side of normal. The body fat mass in kilograms as well, the weight had reduced to 25 kilograms after 6 months. That's 25 kilograms out of 71 is fat, and 25 kilograms out of 71 is muscle. But now look at the measurements. Look at the measurements. We got down with the waist circumference to 104 and then to 96, and with the chest circumference to 99, and with the hip circumference to 99. So look, you've converted someone from central obesity to someone with actually a waist. So now she's got a better looking shape, a decent lean muscle mass, and with a full treatment to her metabolic syndrome. Let's remind ourselves of the overall parameters. Remember, preoperatively, when she came to clinic, she was 82 kilograms. 6 weeks after optimization, 6 weeks with optimization, she gained 5 kilos to 87 kilograms. 3 months later, she's down to 78. 6 months later, she was down to 71. So the weight loss she's gone through over 6 months compared to very first presentation is almost about 13 kilos. 12 to 13 kilos, which is not bad. And she's a lower BMI anyway. The BMI on presentation was 32.5. BMI after optimization went up to 34.5. BMI reduced to 29 3 months later and down to 25 6 months later. HbA1c on presentation was 6.8, and 6 months later it was down to 5.2. So thinking 11 or 12 kilos of weight loss brings down the HbA1c from a diabetic to a normal level. Yeah, that's the treatment for metabolic syndrome. Now let's again look at the skeletal muscle mass, and here is where the difference comes. When you've seen this patient on presentation, she had a skeletal muscle mass of 22 kilograms. 6 months later, after she lost her 13 kilos, she was up to 25 kilograms of skeletal muscle mass. So after losing weight, she has more muscle than she did on the time of presentation. And we believe that that is because of the optimization we've done. But this is only theoretical. I'll be happy to take your comments and discussion later. In terms of the body fat, she's reduced from 33 to 25. You would like these measurements. I love those measurements. Look at the measurements. We were pure, hardcore central obesity. And after losing 11 or 12 kilos, we're down to completely changing the body shape into a normal body shape with the waist, the chest and the hip being 99 and the abdominal girth 96. So after 6 months, HbA1c was down to normal. This patient had discontinued the diabetes medications by her diabetologist. Lipid profile down to normal, so she's discontinued the anti-lipid medications. The thyroxine dose had reduced to 50 micrograms per day as compared to 75. Her back and knee pain was very well controlled, and actually she was able to do exercise, long walks, and mild cardio. So in conclusion, body composition analysis helps to determine the muscle fat distribution. It helps you to decide what optimization you'll give to your patient. It helps you to decide the surgical plan. And it helps you to follow up and set up the outcome goals after the surgery. So what are the expectations and goals? I think what we've achieved with that patient is a dream to every healthcare professional, whether being a bariatrician or any other specialty, especially for the dietitians out there. I'm sure you've enjoyed that case presentation because that's what you want to see for all your bariatric patients, I'm sure. So the goals are in terms of treating metabolic syndrome and reduce the need for medications, the psychological and emotional well-being, the self-esteem, the social confidence, better performance. And in terms of the cosmetic factors, we always encourage follow-up with the cosmetic team for hair, nail, and skin. And we encourage exercise like gradual cardio and muscle strengthening. For the nutritional status, I'm sure my colleagues, the nutritionists out there in the audience would give their goals, but I always aim for regular follow-up with the, 6 times for the first year and twice for the second year, and then yearly thereafter for 5 years. I like to follow up my patients for long term because I come up with research and study for many different points. be it comparing the different procedures or even how to perform different procedures. We like to replace any deficiencies post-bariatric surgery, and we like to encourage balanced and high-protein diet. I learned from Kim that there are some pediatricians out there in the audience. So this case is for the pediatricians. Pediatricians, you always have your concerns about surgery on teenagers and adolescents. Many of you believe that we can tackle childhood obesity with changing lifestyle, with education, with awareness, spreading awareness. Yes, I do agree with you. But every now and then you get morbidly obese children whom you really have to help, even if it means surgery. Look at this case. This is a 15-year-old male patient, came to our clinic with a BMI of 50. Now, he's only 15 years old. That's not even enough time in life to develop a BMI to 50. His mother and father, his parents claimed that he tried the diet and exercise and he failed all attempts. But they also admitted that he's a fast food eater, he drinks a lot of soft drinks, and he eats sweets and chocolates. This family had a family history of diabetes, hypertension, obesity, and metabolic disorders. So if you look at the parameters, this is just to show you how helpful body composition analysis is, rather than to show you how successful surgery was, but his surgery was also successful. If you look down, look at the body fat mass. He reduced the fat mass from 69.6 to 26.4 1 year after surgery. He was almost 70 kilograms of fat, and that reduced to 26 1 year after surgery. Skeletal muscle mass, he was 35, and he's reduced it to 25.7, which is not bad. And I'll show you his weight. He had lost almost 70 kilograms of weight, and his lean muscle mass wasn't much affected. But we've optimized this patient very well. Let me go ahead and show you the parameters. So the pre-op weight was 131 kilograms. Post-operatively 1 year, he reduced to 63 kilograms. His body mass index in 1 year dropped from 50 to 28. Look at the iron is better. It was 39. It was 1 year later, it was 80. So obviously his procedure did not cause him any deficiency or malabsorption. Total protein in the serum before the surgery 7.2, 1 year after surgery 7.1. Albumin before surgery 3.5, 1 year after surgery 3.8. And now the fat mass index was 70 before surgery and down to 26 1 year after surgery. The skeletal muscle mass, not much of a drop from 35 to 26. So the conclusion, yeah, we've optimized this patient as well. Being in a growing age, again, there is no guidelines for this. This is just observational. I remind you, this is observational numbers from my clinic. Proteins and amino acid supplements was given to this child for 3 months with preemptive muscle strengthening physiotherapy. So we've optimized this 15-year-old patient for 3 months before we did his surgery. The recommendation from the physiotherapy department that we give 12 sessions of muscle strengthening physiotherapy, which we've done. And we've given essential amino acids, as I said, for the 3 months. So in conclusion, bariatric surgery is life-changing if done properly, right surgery for the right patient. And if we control the expectations and control the unwanted future events like muscle loss, hair loss, dumping syndrome, staturia, diarrhea, then you end up with a successful surgical procedure. Always remember to assess your risk, benefit, and no benefit ratio. If you know how to assess your patient right, you will know how to calculate these equations. And these are some references for you to read about. Thank you very much. I hope you've enjoyed this lecture. Thank you.
Thank you, Dr. Inas. Before we proceed with the questions from our attendees, we would like to have a short presentation with our sponsor for today's SpecBright Group. We have Engineer Syed Sashan to give us his presentation. Mr. Syed, you can share your screen.
Hi, Kim.
Hello, Mr.
Can you
Syed.
start now?
Yeah, you can start now. Can you share your screen, please?
Okay. Hello, hi, good afternoon. Thank you very much for your time. And I was listening to Dr. Inas, so she covered almost most of the topic, which I will cover some of the part of it because when you do the surgery after the loss of the after the surgery, it is very important to maintain the healthy body composition because the patient tends to regain weight when they do not maintain a healthy lifestyle and do not do the exercise. So when it comes to the to do the monitoring of the body composition, so there's obviously the device comes and we represent InBody. So it's always good to get all the information which doctor talked about, so you can see really what your body is composed of and what are the parameters you really need to look into it. So I'll cover some of the topics today, and I'll try to finish my presentation within the given time. So I'll be covering the topic of monitoring the body fat mass, which is very important too, then monitoring the fat-free mass, and a very interesting article of body phase angle, which I will just give you a brief overview, and I would appreciate more questions, more interest about the phase angle, which we can discuss later on, like what are the informations you received when you get the body phase angle. Okay. So now the body, when you see like the InBody result sheets, so our excuse me. Okay, so this is how the result sheet looks like, InBody result sheet. So when you see the InBody, sorry, are you seeing my screen?
It's your computer screen. Can you share again? Great.
Very sorry. Okay, so this is the InBody result sheet. You will receive it. Okay, so based on the bioelectrical impedance analysis, you will get the body composition analysis, first of all, which is you will get the information about the total body water, soft lean mass, fat-free mass, and the fat mass. Then we have a segment called body fat analysis. So you will see the comparison between the weight, skeletal muscle mass, and body fat mass. For obesity analysis, we have two parameters. Dr. Inas used the common word of BMI, and the percentage body fat also needs to, because the BMI shows you the appearance, and based on that, you really need to see if the BMI is higher. So what is the amount of fats being stored in the body? So you really need to see the percentage body fat as well. Since our device does the segmental body analysis, so you will get the segmental lean information, okay, segmental ECW ratio information, okay, and the segmental fat analysis as well, okay, and the total body extracellular water ratio. There are some additional parameters which is kind of useful for the dietitians to look into it, because since InBody uses direct segmental multi-frequency analysis. So it will give you the information about the intracellular, extracellular water values, the BMR, body cell mass, and skeletal mass index as well. Okay, so the raw information is the body phase angle, which I'll be talking about briefly in my last slides. But this impedance is the value which the InBody takes as the raw data. Okay, and then it gives you all this information. Okay. So now, considering the post-surgery cases, as I told, the patient tends to regain the weight. Okay, so one of the most common side effects are the after the bariatric surgery, is the regaining of the weight. Okay, so and it's the weight regain is not common in patients undergoing bariatric surgery, because it can be expected that 20 to 25% of the lost weight will be regained over a period of 10 years. Okay, so we see it in the form of examples here. So in order to prevent weight regain, continuous and intensive management is necessary. Okay, so continuous visits, follow-ups, and can really affect positively on the weight loss maintenance. So here we see the 2 surgery cases. So whereas the patient was doing not very regular visits, so you can see the amount of weight loss, it's been increased. Okay, excessive weight loss has been increased, whereas when the patient does the regular visits, so he quite maintain the excessive weight loss values. Okay, so it's always better to do the regular visits and keep monitoring of your fat loss. Okay, so and I'll be using a lot of research studies, because these research studies are being done on InBody. So in this research study, I'll be talking about the amount of lean mass, how it relates to the amount of after the surgery. What is the relationship between the loss of hand grip with the LST, lymphocyte stimulation test. Okay, so our data shows that the closer monitoring of the body composition and suggests that clinical protocols to maintain the LST and muscle strength may be warranted in bariatric surgery. Okay, so after the bariatric surgery, so it's always very important to monitor the loss of lean mass as well. Okay, so we have all the research studies which we can share you later on after the presentation. So now when you're doing the monitoring of the body fat mass, okay, so after the surgery, you wanted to see how the results looks like. Okay, so and the patient can go in a in a right way, or in a right direction, or it needs to some kind of improvements. Okay, so when you see the results from InBody, so you see it like the body composition history is here. Okay, so you can really monitor the body fat mass, okay, with the InBody, and then you can exactly see what changes you need to maintain. So our device provides the complete body composition history. Let's say the amount of visits the patients make, and the amount of changes being done on with respect to its weight, skeletal muscle mass, or percentage body fat, with the extracellular water ratio values as well. So you can see the constant monitoring helps them to maintain the skeletal muscle mass. At the same time, you can really see the fat mass to be controlled. Okay, so here I give you an example of a person. She did the data before the surgery and after the surgery. So you see her weight is 100.4 kgs, whereas skeletal muscle mass is 32.6 kg, fat mass 42.3. Percentage body fat mass, body fat is 42.2%, skeletal muscle mass is 32.6. Okay, so when you see after the surgery, okay, her information, like after the 4 months, okay, because she was being constantly monitored and being analyzed with the help of a body composition analyzer. So if you see that she has done a drastic drop in the weight from 104 to 96, but after consecutive visits and consultation with the doctors, she is able to maintain the weight loss of 84.5 kg, which is a great achievement. You can see that skeletal muscle mass being maintained at 30 kg, whereas the fat mass is being reduced to 30.8 kg. So as what Dr. Inas also said, like the rehabilitation, the exercise, always helpful for the patients to maintain the healthy body composition analysis. So it's always good to see the results and to keep the monitoring of certain parameters, which are like mostly the skeletal muscle mass and body fat mass. Okay, here kind of information I would like to share you, which is again there is a detailed study in it. Okay, so I'll just quickly overview it, and I'll be more happy to to explain it to you in detail. Okay, now see, now the body composition, actually when the fat-free mass increases, okay, it plays an important role in energy expenditure. Okay, so the components of the fat-free mass are the greater determinants of resting metabolic rate. Okay, so now if you see, the studies been found that for each 1 kg of lean mass lost after the surgery, there is a loss of 18.6 kilocalories per day. So some studies also suggest that the changes observed in RMR after the surgery may be explained exclusively by changes in the fat-free mass. Okay, so the reduction of the resting metabolic rate, actually from the 6th and the 12th post-operative month in the surgery, patients were significantly correlated with the decrease in the lean mass. Okay, so however, there is no relationship with the fat mass. So how's being monitored and how's being checked always, because energy expenditure is directly proportional to the basal metabolic rate, and again proportional to the body lean mass. So this is very important tool to monitor, to be monitored. So if you go with the calorimetry procedures, these are like expensive and takes longer time. So whereas you can simply use the InBody, which takes hardly 1 minute to get all the results as a printout, which I showed you in the first slides. So you can really monitor the weight loss, and you can really make the healthy lifestyle and healthy body composition. Okay, so here again there is a study which is very much related to the information what we will be getting it from the body composition. Okay, so nutritional assessment, the lean body mass depletion at hospital admission is associated with an increased length of stay. What does it mean? Like low fat-free mass at hospital admission is significantly associated with the longer length of stay. Okay, so people who have higher fat-free mass, if in layman, if I talk about, so if a person having a higher fat-free mass has a minimum length of stay in hospitals, whereas the people with the lowest fat-free mass have higher length of stay in the hospital. So this is always correlate to the fat-free mass, information with the nutritional assessment. Okay, so now the second part of the topic is, because we talked about that how you can constantly monitoring the body fat mass. So body fat free mass is also very important to be monitored. Okay, so as I said, like basal metabolic rate is directly proportional to the muscle mass. So and the lower the basal BMR, higher the chances of weight regain. Okay, so by monitoring the muscles and segmental lean information, you can prevent your patient from weight regain. Okay, if you see it here, so you can segmentally see the lean analysis. Okay, and with the help of this information, you can really compare the body analysis, the lean analysis from right to left and upper to lower body. Okay, so this is always a very good tool to maintain, to increase the muscle. Okay, the muscle mass, and if even for the lower limbs, if it's like under range, so it can lead to more complex problems, because the thighs covers the 2/3 of your muscles, so of your whole body. So you really need to maintain the good muscles by doing the exercise and maintaining the high healthy diet plan as well. Okay, now phase angle, actually it tells you about the overall nutritional assessment of the patient's body, but here we are using this body phase angle as a predictor of a weight loss success rate. Okay, so how successful your surgery is. Okay, so it's been determined with the help of a body phase angle, and it's found that that the cutoff angle of 3.9 degree, okay, was calculated as the most suitable cutoff for a successful operation. Okay, so this is a very important tool. When the body phase angle goes 4 degree or above, that means most of the cases the surgery is being performed successfully. Okay, and then we have a detailed research study on this, that what are the informations and how you measure the body phase angles, and what are the informations you get it when it goes higher or lower. Okay, so with that I can share with you if someone is interested, so you can share the information with us, and so I'll be more happy to share you the more research documents. Okay, so in the end, I would like to highlight and summarize like the bariatric surgery, how we can use the InBody in bariatric surgery. Okay, so since there are a lot of parameters which I talked about, but there are still some of the information which I didn't talk, and it needs again a complete presentation. So I'll just quickly overview it, and then we can talk in detail later on after the presentation. Okay, so for the pre-operation procedures, okay, you need to distinguish between the obesity type. So it's like highly obese, severely obese, or sarcopenic obesity are the issues, so it's related to your body fat percentage, it's related to your extracellular water information. Okay, or if you wanted to predict the outcome of the surgery, which I talked in my last slide. So if an unhealthy cell membrane or it's a healthy cell membrane, so you really need to see that patient is prepared for the surgery. Okay, so we need to see the phase angle. Okay, so for post operations, you do the nutritional assessment, you see the muscles, you see the fat-free mass contents. Okay, and when you are monitoring especially for the edema, so you really need to see the extracellular water information. And since InBody is capable of giving you the segmental extracellular water ratios, so you can really see segmentally the accumulation of body fluid. So I hope this helps you to understand the basic concept of the BIA and the basic concept of what InBody 770 can produce. So thank you so much. And if you have any inquiries, you can send us the inquiries on our email address, and we'll be more happy to assist with you. Thank you so much.
Thank you so much, Mr. Sajan, for your presentation. We'll also keep your email address on the evaluations and the post-test that we will be sharing for any attendees who would like to post any questions, clarifications, or comments. In the meantime, we would like to proceed with some questions with Dr. Ines. I will put your mic, Mr. Sajan, on mute, and I will bring you back to the attendee. All right, Dr. Ines, before we proceed with the Q&A, can we go ahead and giving them the poll questions? As I can see on the pretest that we have released, most of the correct answers we got are the low responses. So we'd like to see if we can explain to them what are the correct answers for our questions.
Can I see your slides, Kim, please? Yeah.
Yes.
So we wait until everybody answers?
At least most of the responses.
Yes, congratulations to the 55% who answered this right. Of course, any bariatric procedure can be associated with lean muscle mass loss, but it all depends on the patient's status preoperatively. But the most, if you look at the question, which bariatric procedure is most associated with lean muscle mass loss? Well, the answer is biliopancreatic diversion. Biliopancreatic diversion. So the 7% who answered these questions correct, I mean the 55% were right. All of them can cause lean muscle loss, but the most procedure that is associated with muscle loss is the biliopancreatic diversion. So the 7%, congratulations. So which procedure, dietary protein intake might be enough to maintain healthy muscle mass? And Roux-en-Y gastric bypass, unfortunately, is not the correct answer. The correct answer here is the mini gastric bypass, especially if tailor-made according to the patient's needs. In the mini gastric bypass, we actually measure the biliopancreatic limb, and the measurement of the biliopancreatic limb decides how much protein malabsorption will happen. So now, recently, the way we do mini gastric bypass is to measure the biliopancreatic limb to a length where suits the patient most. So there is not a standard length or measurements for the MGB, at least the ones I do in my practice. The sleeve gastrectomy is a restrictive procedure, so you're just not eating enough. You're just not taking in enough. So it's very difficult to take enough proteins orally. Even if you take protein supplements, they're too bulky. The sleeve gastrectomy would not tolerate it. So that's the wrong answer. The biliopancreatic diversion, it's associated with severe protein malabsorption. So you need a lot of supplements, to help them with to maintain a normal protein intake. But dietary protein alone, what they eat in their meals, is never enough in the biliopancreatic bypass. Similarly applies to the Roux-en-Y gastric bypass. Duodenal switch is also a very severe procedure when it comes to protein malabsorption. The mini gastric bypass, in my opinion, certainly in our department's opinion, is the best procedure when it's tailored according to the patient's needs. We very rarely see patients with huge lean muscle mass loss, and it's usually, I would consider it as the better procedure in terms of protein absorption. So the correct answer for this question is mini gastric bypass, and congratulations to the 18% which answered it right. Thank you, Kim. Very well done. So Kim, only 30% of your candidates were actually listening to me when I was discussing the first question. We've already said this in the first question. Biliopancreatic diversion is the worst procedure when it comes to protein malabsorption. So the answer to this question is biliopancreatic diversion. Congratulations to a third of the audience. Thank you. Yeah, I accept that it should be between at least 5 to 10%, but unfortunately, that's not what our data shows. In one of the EFSO, international EFSO conferences, we've gathered almost a group of 200 healthcare providers, surgeons, and different specialties, and we asked them about the assessment. And actually, we found that less than 5% assess their patients well and decide which surgery is suitable. We found that most surgeons are, they've got a certain preference to a certain procedure. So those who prefer a bypass, those who prefer a sleeve, offer a sleeve to most of their patients. So unfortunately, the correct answer here is the first one, which is less than 5% of clinics, not only nationwide, but I would say worldwide, that assess their patients thoroughly before deciding which surgery is suitable. I hope this question helps you. So a patient with body mass index of 40 and no associated comorbidities. He's just obese. He's got a hiatus hernia, which is asymptomatic. He's got no symptoms with the hiatus hernia, and he's got a high speed of gastric emptying. So I would decline a restrictive procedure because this patient has got an asymptomatic hernia, which can later become symptomatic with a sleeve. So I wouldn't go for a sleeve gastrectomy. Although he's got a asymptomatic hiatal hernia. The speed of gastric emptying is fast, so a restrictive procedure again is not going to be helpful for him. So the first and the second answer is out. The third answer is Roux-en-Y gastric bypass alone, which I think that is the correct answer, in my opinion, because you will choose a malabsorptive procedure because of his high speed of gastric emptying, and he would not respond to a restrictive procedure. And the asymptomatic hiatal hernia, because the Roux-en-Y gastric bypass is actually a low pressure system, so it would actually help to reduce the symptoms if there are any, and certainly in an asymptomatic hiatal hernia, a gastric bypass procedure is enough. So in my opinion, I would go for either a Roux-en-Y gastric bypass or a mini gastric bypass. In most practices, we go for the Roux-en-Y gastric bypass. That's the correct answer. Yes, I agree with the majority that with normal gastric emptying, this patient would benefit from a sleeve gastrectomy, but with an asymptomatic hiatal hernia might become symptomatic after a sleeve. So I would do exactly the same. I would do the sleeve gastrectomy with fixing the hiatus hernia on the same session. So I agree with the answer. Thank you. Kim, there was more to this question. Some parts of the question is not appearing. The continuation of the question is that he had the hiatal hernia as well. Anyway, the idea of this question is you don't go from restrictive to restrictive or from malabsorptive to malabsorptive. So this question tells you that this patient had a good surgery by a reputable surgeon from a reputable organization. So surely the surgery went well. But what's happening with this patient is that he's suffering the side effects of the gastric bypass, and he's not benefiting from the gastric bypass. The continuation to this question was that he had severe hiatal hernia and severe reflux symptoms. So the answer was going to be hiatal hernia repair as a restriction and giving it a trial. But without that appearing, it's not a bad answer to actually reverse the Roux-en-Y gastric bypass and convert it to sleeve. So this is the 50% who answered convert a malabsorptive procedure to a restrictive procedure. It needs a lot of assessment. It needs a lot of decision making, a lot of optimization to the patient, a lot of discussion with the patient. And then if there is no other alternative, it could be a choice of an option that we can consider. But certainly, with a condition like this, I would consider repairing the hiatus hernia and wait, provided that I have actually tried all the other lifestyle changes and seeing the dietitian, seeing the internal medicine, using liraglutide, trying everything else. The next step for me would be to go and do the hiatal hernia repair. And the third option would be to reverse the bypass and convert it to sleeve. So yes, congratulations to the 50%. I think you're thinking in the right direction, but there are conditions to this decision making.
Thank you so much, Dr. Ines. That ends our poll questions. Now we would like to address the questions left by our attendees. First question, how to assess insulin resistance?
We assess insulin resistance by doing an insulin tolerance test, not glucose tolerance test, but insulin tolerance test. So we do a fasting insulin and then we repeat it again after having a high sugary drink after an hour, 2 hours, and 3 hours. This is called insulin tolerance test rather than glucose tolerance test. So this is how you assess insulin resistance.
Thank you. I knew that isotope nuclear scan is the best tool to measure gastric emptying time, but not a barium meal. Please correct me if I'm wrong.
Well, again, the word best, it's very good to answer questions on a multiple choice or do an exam or whatever, but when you're in the practical world, you need to be cost effective, the test has to be readily available, and the information has to be reasonable in the accuracy. So the isotope scan, it is a very, very good indicator and it is the best, but it's not available everywhere. It's expensive, insurance companies don't cover it, and to get the results, again, you need a radiologist to read it. So with the barium meal, it's cheap, it costs less than 500 dirhams, it's available in every hospital and every radiologist can read it. So in my opinion, the word best reflects availability, accessibility, and cost effectiveness. So I would disagree with my colleague and I would still stick to my barium meal.
Thank you. Which amino acids is recommendable?
Now, as you know, Kim, we've discussed all these details in our previous lecture. Our previous lecture was called Assess, Optimize, and Proceed. So we focused a lot on the essential amino acids and the basic amino acids, and we talked about our protocols. So I recommend, if you don't mind, Kim, is to send a copy of those slides from my last lecture to the candidate so they can learn all about the protein and the amino acid supplements.
Thank you, Dr. Ines. Another question, how many grams of protein supplement are you giving the patient pre-operation?
Well, we aim for 60 to 120, but that depends on the skeletal muscle mass. If that's within the normal range or higher than normal, we don't usually supplement them in our optimization period. We supplement those who are on the lower range of normal and who are below normal. So again, this is not evidence-based, but the evidence talks about 60 to 120 grams per day for the post-operative patients. The preoperative patient with normal lean muscle mass, I wouldn't supplement.
Thank you. Regarding patients with old age and diabetic, when can we say it's safe for surgery?
Well, this is a very good question because this is why I'm emphasizing on the assessment. Please assess your patients one by one and tailor-make their treatment. Don't just put it as a rule, 60-year-old elderly, diabetic. No, I mean, I know a 60-year-old who's a champion with me in my tennis club, and he plays better tennis than everyone, and he's 62 years of age. So am I going to classify him as the frail elderly who can't do anything? Absolutely not. So please assess your patient and don't label your patients. Elderly, diabetic. I agree, but please do not label your patients. Take every patient individually, assess your patients, talk to your patients. Forget age, forget everything, just talk to your patients. However, the 60-year-old elderly, frail, central obesity, taking 20 medications, I would consider my options if I would want to exert surgical pressure on him and give him complications. But a 60-year-old who's very well, who's doing exercise, who's diabetic, but he's with the lower BMI, I would seriously consider surgery. So safety of surgical procedure all depends on your optimization. So please go back to the slides of, depends on your assessment. So please go back to the slide of assess, optimize, and proceed. Because once you assess, you can make your optimization plan. So your job with the optimization is to improve the numbers you come up with during the assessment stage. So if you do the assessment and you realize that, oh, this is a poorly controlled diabetic, there might be a high risk of leak. For example, if that's the point you're addressing, then optimize the patient to bring down this risk. So again, the question is very general. My recommendation is please sit with your patients and listen to them as an individual and do not label your patients under any certain group of diseases. Next question, Kim.
Is it bad to have skeletal muscle mass above the normal level? If yes, why? If no, why there is an upper normal level there?
I don't think it's bad to have a muscle. If you go to the gym and if you do bodybuilding, oh, you'll have much more than normal range of a muscle mass. I have a patient with a body mass index of 70 and his percentage of body fat is less than 10%. So he's not obese, is he? This guy is a bodybuilder. Is a muscle, is a bodybuilder. So having a high muscle mass is not a bad thing. It's a personal choice. You're not born with it. You certainly acquire it. And people with a higher muscle mass index, usually they do a lot of exercise or they go to the gym or they do bodybuilding. You don't often find people with higher than normal range muscle mass and they're doing nothing, sitting at home and doing no activity at all. So having a muscle mass index of more than normal range, it's something that is not bad as long as your patient is healthy and doesn't have any contraindications to that. Why is there a range? Well, I think there has to be a range so we can stick to it. Now, this range helps me to decide how much muscle mass I would like to increase or how much improvement I need before I do bariatric surgery. Obviously, if I'm forced to do a very severe malabsorptive procedure, I'm very concerned about losing muscle mass. So it's not possible for me to do the surgery starting with a patient with a lower range of the skeletal muscle mass. So I would optimize them, bring up the muscle mass percentage, and then do the surgery.
Thank you. As a nutritionist, how can I manage the dumping syndrome that happened after the surgery because it differs from patients to others?
You're very right. As a nutritionist, there is a lot you can do, but you do need a gastroenterologist on your side who understands bariatric surgery. With all due respect, I respect all specialties, all teams, but bariatric surgery is something very generally addressed. Bariatric surgery is very, very generally addressed. To the extent we have problems, anything that goes wrong with the patient after bariatric surgery, the bariatric surgery is blamed for. Let me give you an example. I have an ENT specialist who's specialized in allergy. Patient goes to him with allergy, with sinusitis and allergic hay fever. and the surgeon diagnoses it as secondary to bariatric surgery. Now, how is hay fever and allergy is caused by bariatric surgery? What he led his patient to believe is that this is all acid reflux coming up to his nose, giving him the sinusitis. So I'm just giving you an example to our dearest, to our dear nutritionists who asked the question, is that pick your medical team right. Pick your physicians, pick your doctors, pick them. You know, don't just go and ask anyone. Try to discuss with these physicians and with these specialists and see who actually understands the science behind bariatric surgery. So dumping syndrome, as you know, dumping syndrome, is it hypoglycemic attack? Is it a diarrhea attack? Is it a fainting attack? Is it a low blood pressure attack? You need a good gastroenterologist who understands bariatric surgery, or an internist who understands bariatric surgery to guide you into what to do. But in general, we find that dumping syndrome is usually due to high speed of emptying. So if the stomach empties very fast, especially if the gastric pouch is loose, or if the gastrojejunectomy is loose, then whatever you eat goes to the small bowel very quickly. And that speed is associated with dumping syndrome. We, in this case, recommend, again, don't take it as a protocol, please assess your patient, find the diagnosis. But in our practice, we find that medications which reduce the speed of gastric emptying, like a metoclopramide or buscopan, scopinal, these help a lot in controlling the dumping syndrome. But please, have in your pocket a physician who you can trust in diagnosing the post-bariatric surgery symptoms, and make sure there is no other reason causing it or other issues, and you're blaming it on dumping syndrome. We had a patient 5 years after gastric bypass surgery who presented to us, she's done her surgery elsewhere, presented to us with hypoglycemic attacks and dumping syndrome, which was induced and started 5 years after the gastric bypass surgery. Now, every clinic she went to, she was told, this is dumping syndrome, deal with it. Now, we've assessed her thoroughly, and we found that she had an insulinoma. So she's developed an insulinoma 5 years after bariatric surgery, and developed the dumping syndrome symptoms. And it was blamed on the gastric bypass surgery. So again, my dear dietitian, please discuss these issues with your doctors and try to find out the diagnosis. Do not blame it on bariatric surgery unless it's otherwise proven. So prove the diagnosis, and then we can discuss the treatment. You can send me questions. I could give you our experience in our clinic with dumping syndrome, and we can certainly guide you. The only thing is, my recommendation is, please diagnose your patient. Good luck.
One more question regarding kids. If preoperative optimization helped within 6 months, what about vitamins and minerals deficiencies and growth effect?
Yeah, this is a very good question. Again, back to my previous lecture, assess, optimize, and proceed. Do not put one bariatric procedure and apply it on a patient group. Just because he's a pediatric patient doesn't mean that all he qualifies for is a balloon or a band or a sleeve. So please assess your patients. The case presentation I gave you earlier was a 15-year-old with a body mass index of 50. So are you going to put a balloon on him just because he's 15-year-old? Is his age a reason for you to choose the procedure? Okay, now when it comes to the pediatric population or the teenagers or the adolescents, people are very scared, they're very uncomfortable, and would actually see a surgical intervention or a surgical treatment as a crime to mankind. So please, no, if you have a child, assess the child. I know you're worried about vitamin and mineral deficiency. Well, assess your child and see what procedure is suitable for him. Now, in the case presentation, which I did, and I have no restriction at all, and I would tell you that I have done a mini gastric bypass on that patient, and I've shown you the slides. Can you please send on the slides? Let our audience look at the pre and post-operative parameters. His iron levels got better after he lost the weight. 1 year after surgery, he lost 70 kilograms of weight. His iron, his calcium, his total protein, his skeletal muscle mass, everything actually improved rather than got back. So please, bariatric surgery is not there to kill people, okay? It's there to improve their lifestyle, improve their daily life. So operating on children, yes, you do need a lot of care and attention when you're doing the assessment. You do need the pediatric endocrinologist to try with them, and you do need a referral from the pediatric endocrinologist. As a bariatric surgeon, I don't go out there and invite children to my clinic. I don't agree to see children in my clinic unless they are referred to me by a pediatric endocrinologist. And then we take over the assessment. And we do have a protocol for the pediatric population. I'm happy to share, or maybe in our next presentation, Kim, perhaps this is a topic people would want to learn about, is bariatric surgery for teenagers and adolescents. We can talk about that. But my answer to the question, are you worried about vitamin and mineral deficiency? Yes, I am worried, and they happen when we do surgery without assessing our patients. In fact, believe it or not, I have data to prove that the sleeve gastrectomy in this group of patients gives them more mineral and vitamin deficiency than a malabsorptive procedure, which is very well measured, very well tailored towards the patient needs. Forgive me, I'm not being defensive about this, but this is something a topic that breaks my heart when it comes to the pediatric population and to the elderly population, as if they don't have the right to health. And you know what? Bariatric surgery is there to treat patients and give them better life. Our job as surgeons is to assess and do the best for our patients, not just to do surgery, but we need you every single specialty who's there in the audience listening to us this evening. We need to put our hands together. We need to be together to make decisions for our patients based on scientific information and evidence base. And if there is anything that I don't have evidence for, well, you know what? The level 5 strength of evidence is observational. And I've got a lot of observational data and that we build our protocols on. So I'm not saying go with the observational data, look into the literature, but the literature doesn't have answers to everything. Whatever question you have, a clinical question, audit it, start treating it, and look into it. Go through an audit cycle every 6 months, look at the improvements and change the audits, change protocols. This is what we do in our department, and I'm very happy to share all this information. I hope I've helped in answering the questions, Kim. Thank you.
Thank you, Dr. Ines. I know you're a very busy person and we have received a lot of questions. We just want to address one more last questions before we end. Are there conditions that can affect the accuracy of BCA?
Yeah, a lot of conditions. How accurate is a BCA? Would I base my treatment plan on one BCA reading? No, and I'm sure the representatives from InBody would agree with me that you need to do a series of at least 3 to be able to trust the readings. Now, the sensitivity and the specificity of the body composition measurement is good enough for me. It ranges between 80 to 86%. For me, it's good enough. It's cost effective, as I said, it's readily available. I could do blood tests to look into the protein and amino acid profile and what have you, but these are very expensive and they're not covered by insurance companies. So are there factors that affect the accuracy of the BCA? Yes, there are. I think one of them is being on the period, for example, water retention, carrying your mobile in your pocket, wearing a lot of gold and metal and accessories. All these affect your readings. But what we do is we only trust the readings if they are similar over 3 consecutive readings and at least 1 week apart. I hope that answers you.
Thank you so much, Dr. Ines, and thank you so much for your time. Really, it was a wonderful presentation. We have received good comments. It was a very nice presentation, informative. It was really intensive. It was always a great lecture with you. Before we end for today's course, we just wanted to ask if you have any information to add.
Well, for me, this is all, the discussion is very important, and I learned from you, you learned from me. I need you in every different specialty. And please do not do bariatric surgery without having a senior dietitian on board. You as a surgeon can do it. We can't cope. We're surgeons. We're there to operate. So we need the dietitians. So for all the dietitians in the audience and all the other specialties, but dietitians specifically, we need you. Bariatric surgery wouldn't start or end without you. Me as a surgeon, I absolutely refuse to work without a dietitian. And I would like to take this special opportunity to thank my senior dietitian, Dr. Hibba Krajia. Please, if you're listening, thank you very much for your support to my clinic. My dietitian supports my clinic to no limits. She's put protocols, she put guidelines, she assesses the patient, she psychologically supports our patients. So dietitians in the audience and all around the world, thank you very much to your support to the bariatric surgery services. Thank you.
Thank you so much, Dr. Ines. And like as you mentioned, we will be sharing with them the presentation of today's lecture and the previous one that would explain the bariatric surgery during the procedure, the optimize, and the prosing.
Thank you.
All right, on behalf of the TIF, once again, we would like to thank everyone. And I'm talking on behalf of Professor Aisha Al-Dahiri, the chair of NHS 2020 webinar series. And we would like also to thank the participation of SpecBright Group for sponsoring today's course. Once again, please be reminded that the course attendance was monitored for the number of minutes that the attendees were connected to calculate the CME hours you will be receiving. Once we have gathered and finalized all attendees' minutes of attendance, you will be receiving an email from us next week with 2 links for post-test and evaluation as a prerequisite of DOH. For those who will complete both links, we will send within 10 working days the copy of your PDF certificate along with the presentation of the course. Please note that the online post-test and evaluation portal will only be open for 1 month from the date of the course. Make sure that for those who are able to attend, to fill out both forms to get your certificate. We kindly invite everyone to please follow, like, subscribe our social media accounts: Facebook, Twitter, Instagram, LinkedIn, and YouTube under the TIF Health Treatment Undertaking Services to receive the announcement of our previous courses as well as view the previous recorded session. With that, for those who are unable to join and for those who are unable to join us from the beginning, we kindly request everyone to please visit the TIF's YouTube channel as our session today is being simultaneously live through YouTube and as well as on Facebook. We would also like to take this opportunity to invite everyone to attend our next 3 webinar series upcoming. The next one will be on Saturday in partnership with Abbott Laboratories SA. Our speaker will be Dr. Amjad Jarar. The third one will be sponsored by Nestle Health Science. That will happen on October 31st. Our speaker will be Ms. Wapa Ayesh. And the fourth one will be soon to be announced. So once again, attendees, panelists, and Dr. Inas, thank you so much for your time and for sitting and staying with us for an hour and a half. Our today's lecture is accredited with 1.5 CME hours from DOH. So for those who have any further questions, clarifications, you can direct message us, and those unanswered questions, we will share them with Dr. Inas for any clarifications, and we will share the answers soon. Thank you so much, everyone, for your time, and stay safe.
Thank you.